Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose, mainly for fourth year students. This topic will be also very helpful to you in your everyday practice as well as in your oral exam, and good number of time it will be given to you in your theory also. So we'll be discussing on examination of 8th cranial nerve. I'll be dividing into two different parts. One will be tuning fork test, that is Weber's and Rinnes test, and second part will be vestibulo ocular reflexes, that is Dolce movement and caloric test. So 8 cranial examination, Rinnes test, Weber's test, and vestibulo ocular reflexes, that is Dolce movement and caloric test. Now just listen to this. This is regarding Weber's test and Rinnes test.
Test. The clinical examination of hearing loss should include differentiating between conductive and sensorineural hearing loss. There are different causes of sensorineural hearing loss, such as inner ear disease or damage to the cochlear nerve. In all cases, the perception of sound waves via both air and bone conduction is impaired. Sounds reaching the affected ear will therefore be perceived to be quieter than on the unaffected side.
So both air conduction and bone conduction will be reduced.
Conductive hearing loss, on the other hand, is caused by diseases of the middle ear, such as otosclerosis or otitis media. Obstruction of the outer auditory canal, as seen in cerumen impaction, for example, can also lead to conductive hearing loss.
Also
In this
wax,
case, air conduction of sound
foreign
waves from
body
middle to inner
will also
ear is
produce
impaired.
in conductive
Bone
deafness.
conduction, however, is
give,
unaffected and causes sounds on the affected side to
so
appear
bone
louder.
conduction will be better than air conduction on that side.
There are two hypotheses that attempt to explain this phenomenon. First, it is assumed that impaired sound conduction causes upregulation of the inner ear, which makes it more sensitive towards stimuli received via bone conduction. It also causes these sounds to be perceived as louder. Second, if sound waves cannot easily reach the inner ear, they probably cannot exit it easily either. These trapped sound waves could therefore make patients perceive sounds as louder. The Renee and Weber tests can help differentiate between sensorineural and conductive hearing loss. The Renee test enables unilateral comparison of bone to air conduction and takes advantage of the fact that physiologically, sound conduction is more efficient via air than via bone.
So in a normal person, air
Place a
conduction is always
vibrating
better
tuning
than bone
fork
conduction.
against the mastoid bone.
This is bone
Sound waves
conduction.
now travel to the inner ear via bone conduction. As soon as the patient can no longer hear the sound, hold the tuning fork next to the patient's ear.
This is air
The
conduction.
sound waves are now conducted via the air. Patients with conductive hearing loss are no longer able to hear this sound since air conduction is severely impaired. Therefore, the Renee test is negative.
So Rinnes
In
test will
healthy
be negative
patients, but
if
also in
air
patients with
conduction is
sensorineural hearing loss, air
affected
conduction will
or it
always
is
be
less
more
than bone
efficient than
conduction,
bone conduction,
and that will be in a
as
conductive
such,
deafness.
the sound of the vibrating tuning fork should still be heard. This describes a positive Renee test. Alternatively, the test can be sped up by first placing the tuning fork against the mastoid bone and then, after a few seconds, holding it next to the patient's ear on the same side. If the sound is perceived as louder, the test is positive and air conduction is intact. Should the sound not be perceived as louder, the Renee test is negative and conductive hearing loss should be suspected. The Renee test should always be accompanied by the Weber test to detect the origin of hearing loss and possible inner ear damage. The Weber test compares
Now
bone
this is a
conduction in
demonstration
both
of Weber
sides.
test.
Start by placing a vibrating tuning fork medially on the patient's head.
On the vertex or on the forehead?
The sound is now transmitted via bone conduction. Physiologically, it should be heard centrally, or, in other words, equally loud in both
In a
ears.
normal person, it will be equally
Unfortunately,
heard on both
the
the
patient
sides.
reports the same finding in both bilateral conductive and bilateral sensorineural hearing loss. This can be the cause of falsely diagnosing a patient as healthy. If the sound is heard louder on one side, this is called lateralization. It can have two different causes. In the case of unilateral sensorineural hearing loss, sound lateralizes to the unaffected side. For example, in right-sided inner ear damage, the sound is louder on the left side. If unilateral conductive hearing loss is present, sound lateralizes to the affected side, since, as mentioned before, bone conduction results in a sound that is perceived as louder. For example, damage to the right middle ear makes sounds louder on that side. Differentiating between sensorineural and conductive hearing loss is only possible by interpreting results from both the Renee and Weber test. To illustrate, the following test results show the clinically relevant constellations. Weber, lateralized to the right. Renee, positive bilaterally. Lateralization to the right during Weber test could indicate conductive hearing loss on the right side or left-sided sensorineural hearing loss. A bilaterally positive Renee test indicates that air conduction surpasses bone conduction on both sides, thereby ruling out conductive hearing loss. This test result constellation supports left-sided sensorineural hearing loss, as seen in inner ear damage. Weber, lateralized to the right. Renee, negative on the right. Lateralization of the Weber test to the right indicates either conductive hearing loss on the right side or left-sided sensorineural hearing loss. The negative Renee test on the right side underlines that air conduction is inferior to bone conduction on this side, making conductive hearing loss more likely. This can be seen in, for example, right-sided middle ear damage. Weber, no lateralization. Renee, positive bilaterally.
Normal.
A normal Weber test can be either physiological or indicate bilateral conductive or sensorineural hearing loss. The bilaterally positive Renee test signifies that air conduction surpasses bone conduction on both sides. This rules out significant conductive hearing loss. In conclusion, the test results indicate either normal findings or bilaterally equal sensorineural hearing loss. Weber, no lateralization. Renee, negative bilaterally. Contrary to the last case, the bilaterally negative Renee test means that air conduction is inferior to bone conduction on both sides, indicating conductive hearing loss. The unremarkable Weber test points to a symmetrical conductive hearing loss.
Bilateral conductive deafness.
The Renee and Weber tests are easy and quick methods for differentiating simple forms of conductive and sensorineural hearing loss. More complex illnesses, such as combined conductive and sensorineural hearing loss, often result in test results that are difficult to interpret.
This is Dolce movement.
Instant neuro. The Dolce test is used to confirm function of the vestibular ocular reflex, VOR, of the brainstem in a comatose patient. If the brainstem is
So
intact,
this will be
and the head
demonstrable
is turned
only
to
in
the
an
left,
unconscious
the
person.
eyes move to the right. If the brainstem is intact and the head is turned to the right, the eyes move to the left. Let's review the VOR pathway to understand how this reflex
This is the
operates
explanation
in
regarding
response
the
to an
pathway.
abrupt head turn. If the head is turned to the left, the horizontal semicircular canals, which are fixed in the temporal bone, rotate in the same direction. Due to inertia, the endolymph, the fluid within the semicircular canals, lags in the opposite direction. This increases signaling from the ampulla of the left semicircular canal to the left vestibular nucleus and decreases signaling from the ampulla of the right semicircular canal to the right vestibular nucleus. Ultimately, via connections with the abducens and oculomotor nuclei, this results in contraction of the medial rectus on the left and the lateral rectus on the right, which turns the eyes to the right, that is, in the opposite direction of the head movement. If the head is turned to the right, the horizontal semicircular canals rotate in the same direction and endolymph lags in the opposite direction. Signaling to the vestibular nucleus on the right is increased while signaling to the vestibular nucleus on the left is decreased. Ultimately, this results in contraction of the medial rectus on the right and the lateral rectus on the left, which turns the eyes to the left, the opposite direction to the head movement. The presence of this Dolce sign in a comatose patient is a good thing. The absence of a Dolce sign would indicate brainstem dysfunction. Instant neuro!
This is regarding caloric test.
Vestibulo-ocular reflex, VOR. Rapid involuntary movements of the eye, called nystagmus, can be induced using the caloric reflex test. This test involves irrigating cold or warm water in the external auditory canal. In the normal condition, the resulting eye movements involve a slow phase of movement in one direction, called the pursuit, followed by a fast phase of movement in the opposite direction, called the saccade. The direction of the fast phase is used to name the nystagmus. An important mnemonic to help you remember the direction of the induced nystagmus is COWS, cold opposite, warm same. This reminds you of the direction of the fast phase of the nystagmus. Let's take a look at caloric-induced nystagmus in a healthy volunteer, SpongeBob. Cold water in the right ear induces the slow phase of movement towards the right, followed by the fast phase towards the left. Remember cows, cold opposite. The fast phase is to the opposite side. Cold water in the left ear induces the slow phase of movement towards the left, followed by a fast phase towards the right. Conversely, warm water in the left ear induces the slow phase of movement towards the right, followed by a fast phase towards the left. Remember cows, warm same. The fast phase is to the same side. Warm water in the right ear induces the slow phase of movement towards the left, followed by a fast phase towards the right. As the slow component of VOR does not require higher cortical function, we can use caloric testing to assess lesions of the brainstem in unconscious or comatose patients. In these patients, there is no fast component, as this would require higher cortical function. Let's take a look at caloric-induced VOR in coma patient Super Mario. Super Mario's brainstem is intact, so both eyes will have the slow component, so the pursuit only, as this is controlled by the still intact VOR. Let's take a look at caloric-induced VOR in another coma patient, Cookie Monster. Cookie Monster has a bilateral lesion of the medial longitudinal fasciculus, which results in absent adduction, so he will have the slow component only in the eye AB ducting. Finally, we have coma patient Minion Pig. Minion Pig has a lesion of the lower brainstem, so he will have no slow component, as the vestibulo-ocular pathway is damaged. The result is that brain-dead patients have no response, so no pursuit and no saccade to caloric testing. Another way to assess VOR is by using the Dolce Test, in which the head is rotated to the left or the right. The reflex is present if the eyes move in the opposite direction of the head movements, and this indicates that the brainstem is intact. In our bilateral MLF lesion patient, Cookie Monster, adduction is absent. A patient with a low brainstem lesion, such as Minion Pig, will have an absent or negative Dolce sign. Instant neuro!
This is a complete explanation.
Vestibulo-ocular.